So thank you very much. I'm really thankful for John for inviting me here. I'm based down in London at RSA House, and I work in the Public Services and Communities team because we think they're integral. And I am the mental health intern based in that team in London. So I'm going to tell you a little about our project, which I think is really pertinent and adds to a lot of the discussions that we had in the previous session. So our project was funded by the Cabinet Office and had a broader range of partners, and we were basically looking at how to communicate public data so that it's accessible and usable. So therefore, our report's title was Turning Public Data into Public Information. We started with the premise that we need a truer, more up-to-date and more detailed picture of mental health and well-being nationally, and in each area, which is following from the Department of Health cross-department paper published in the last government, at the end of the last government. We genuinely believe that realising the power of data can actually empower communities in order to find the solutions to their own problems, and particularly in the mental health sector. So I've come up with a buzzword bingo of these 3 key steps that we think inform our theory, what people call in their think tank work a theory of change, which is information can help facilitate participation and therefore transform services for people. So that's the executional nexus. And it's also important that the data that I'm about to show covers England, but I'm also going to be talking about Bristol specifically. So we launched in November of last year with a embarrassment of riches. So we had the chief executive of Mind and the clinical director of mental health in the NHS, Geraldine Strathdy, both of whom were in the New Year's Honours list this year. And it was quite nice to be able to send them an email saying well done. And they formed part of our expert panel. And they were at our launch and they had lots of nice things to say. So we got some nice press coverage. There's my boss, Charlotte, on BBC Breakfast talking about our project. And then these are our kind of 2 big key takeaways. So there is an urgent need to review GP and community care services, and also that primary and secondary care data, that should say, must be more easily accessible and integrated, because at the moment they're not, which might surprise you. So as I said, we're focused on mental health, and specifically we started with the problem, which is that people with a long-term mental health conditions, that's psychosis or long-term depression, are likely to die any time between 10 and 20 years, but we were able to nail 12 to 13 years in our data set. A lot of people, when you talk about mortality and people with long-term mental health conditions, will instantly, and one participant also made this association, will instantly think of self-harm or suicide as contributing to that. And what we found in our data is that actually so this is for men and women, that actually more completion of suicide actually relates to a very, very small part of that elevated mortality. So what we're looking at is normal things that kill normal people. So that's to do with preventative illnesses, and that's what we wanted to focus on. So we looked specifically at primary care data, and because also Geraldine Strathdy in our launch said, rather depressingly, pardon the pun, that the majority of people that do go to complete suicide have actually seen their GP in the previous 4 months. So there's clearly something going wrong, so we wanted to investigate it a little bit more. So one of the reasons that we alluded to that we've got this elevated mortality is to do with access to physical health checks. And so through data that we got mainly through the Health and Social Care Information Centre, we were able to identify that there is a huge gap in provision for people with mental health conditions at the primary care level. So you can see here that for the general population, people that are presenting to their GP will be 83% will get access to a cholesterol check, whereas 68% of people with serious mental illnesses will do. And you could almost say that I don't really know how you could possibly justify that, actually, because we're all supposed to live under one system, and actually GPs all have the same quality outcome framework from a directive from government. So really, we're very interested, because this just shouldn't exist. And that's what the power of data can tell you. So we didn't just focus on death. We focused on other areas of health and how that affects people with mental health illnesses. So one of them is access to physical health checks, which we talked about before. Access to IAPT, which is which is access to psychological therapies. And the outcomes of those, so what happens to people when they go through that process. And then we created a Living Well index, which I love, but unfortunately we weren't able to put it into our website, which we developed. And these are some of the key national takeaways that we were able to identify. So as I alluded to, we created a platform which we weren't able to get Jeremy Hunt's quote because there was loads of politics in that, but we got a slightly more junior minister to talk about some of our work, and this is on our website, so you can all go on and see how your area is doing. I don't know why, I just picked Cornwall for that one. So now I'm just going to use said website. So can anyone give me one of their postcodes, preferably not in Bristol? Is anyone from Bath or? Yeah. So what's your postcode? Oh, you can't see it. BA11.
Just while you're doing that, could you let us know why Bristol?
Oh, just because I'm using that data already. So. This is more added information. Oh no, I can't get it out of view. We got there. So if you look at our site here, I knew this would happen.
Just fiddle with the leaves?
No, I just exited the. Yeah.
That's the list of dangerous live acts, not just children and animals.
Yeah, never deal with mental health either. Oh, this is sad. It's quite it's quite a good website. Oh, okay, almost.
Put a split screen on.
Oh, right. So what does that mean? Oh, apologies, guys. Says the data guru in the corner.
Is there anyone on a Mac who knows how to unsplit screen?
Oh God, no. Okay, I'm just going to carry on. But trust me, it's quite interesting.
Or could you just read out the stats? People can see. They don't.
Yeah. Okay. So for where this gentleman lives, sorry, what's the first three letters of your postcode again? BA11. So that's classed as Somerset here. So in your area, you have it's as expected mortality rate for those with long-term health conditions, and actually you have a slightly better life expectancy rate than average. So well done, Somerset.
Could you just maybe turn the computer around?
Possibly.
Don't do it. No. Leave it well alone.
Oh no. Okay.
I think we could crowdsource the information.
Okay, and then I've just checked your the access to physical tests in your area, and again, it's low. So we banded places between high, as expected, and low, and you came up low. And actually, that's a staggering difference, which you would be able to see visually. But for people with a long-term mental health condition, only 47% of them are getting those tests compared to 75%. So that is a massive gap of almost 30 percentage points different. I'll get onto that afterwards. So there's lots of reasons why that might be, but the data in itself can't tell us. Okay, I'm going back. We are here. Okay, let's keep going. We're going to pull this back, guys. Yeah, so that's just, like, we've got lots of data. That's just to try and visualise it, 'cause we're all into visualising. Again, I just got this up from Public Health England. healthierlives.com/whatever is a really good website, actually, if you want to get up to date health inequality data stuff, and it basically just compounds what the director of public health in Bristol was saying before. So anyway, getting on to Bristol. Yeah, so it's healthierlives.org, and then it's linked to the Public Health England website. So if you just type in Healthier Lives, Public Health England, it will come up. It's a really good website. I recommend it. And I'm sure if they were here, this would all have worked. But so mortality in Bristol, as you can see, the all deaths area here is like there's not an elevated mortality in overall. But there is for people with serious mental health conditions. So you are 2.9%, if that's helpful, but 2.9% more likely to die prematurely if you've got a serious mental health illness in Bristol, whereas you're 2.4% in the country. So that is an elevated mortality for Bristol specifically. But it's also just horrendous that that's the case for people nationally anyway. So not for this data, unfortunately, actually. We don't have that. Or we have it, but we didn't present it on the website like this. So then going into access to tests, again, as I referred to, there's a really significant gap between blood pressure tests, cervical cancer screening, and cholesterol tests in Bristol specifically, and it comes out low in our indicators. So that is 35% less likely to receive a cholesterol test, 14% likely to receive cervical cancer screening, and 10% less likely to receive blood pressure tests. So less likely than someone without a mental health condition. Yeah, sorry. Always good to clarify. And then we've looked at IAPT access. So actually, Bristol does relatively well. Specifically lower than average. Yes, so sorry, that's an NHS-run initiative that started in 2008 under the previous Labour government. So in terms of access, actually that should say higher. I do apologise, but nationally it's pitiful. So only 14% with anxiety and depression. Okay, I've got 1 minute left. Oh God. Only 14% with anxiety and depression actually enter IAP services, whereas in Bristol it's significantly higher. So Bristol's doing really well in that regard. Not so in terms of wait times. So this is people waiting longer than 28 days. So 84% of people are waiting longer than 28 days, whereas nationally it's 62. So it's a bit patchy. So people are getting it, but they're waiting a long time for it. In terms of outcomes, as expected, but it does come out below average. So these are the England rates. Anyway, I'll give you all the data so you can properly dig into it, and I'm running out of time. Again, this is whether the likelihood of being prescribed talking therapies versus antipsychotics/antidepressants. So there is a higher prescribing rate for talking therapies rather than antidepressants. And then the coolest bit, which is unfortunately presented in not such a cool fashion is our Living Well Index. So I'll just focus on one thing, which is the gap in employment for people with mental health disorders. And this is related to the local authority, not the CCG. And so that is a 45% percent gap between those those with mental health conditions in employment and those without. So that's one of the highest in the country. So that's Bristol's got an issue there. Anyway, we've worked with Healthwatch in Barnet as a pilot for this kind of new way of delivering kind of data analysis. So my background isn't data, isn't in like stats, it's in campaigns. So I'm very, very focused on impact and what people are actually going to do about it. And that's what really drives me. So we've done this pilot in Barnet, and we use the data to say these are the 3 things that they should focus on. And this is the takeaway for you. We're just about to launch an ambitious partnership with NHS England and these 2 partners on how we create health as a social movement. And I firmly believe that data is a social movement in itself, and particularly open access and open source data. And that has a potential to really improve health outcomes and decrease health inequalities. So I spoke for far longer than 6 minutes, but apologies for the tech problems as well. But I'm really, really keen to get your input, because I think we might be able to go and do some good stuff together. But thank you very much.
Thank you very much, Tom. So there are less presentations this evening, and David Miller, unfortunately, is not able to be with us. So we can afford a few more minutes for questions. I believe. Can you keep that microphone with? Of course, great. There are 2.
I'm loud enough as it is.
It's for the video.
Hi, my name's Daniel. I work with ethical or social businesses, so smaller organisations, some of which are engaged in this area. And it's a great presentation and great data and a really good resource. I'm not a health professional, but I'm really passionate about this area. My question is, aside from data which just describes the problem or the disparity of someone who's experienced a long-term mental health condition as opposed to the average, is there something which describes how the experience of people with long-term conditions in an area which would be considered best practice? So for instance, in Lambeth, there's a great partnership initiative between health, a series of small organisations, peer networks, that has been said to have a great effect on how people manage long-term conditions. And often a barrier for small organisations to deliver a lot of value with the patient is actually their ability to demonstrate their efficacy in a way which is compatible with health system data, which can be a major problem when it comes to commissioning. Mm-hmm. So has it been used as that? Could it be used as that? Are you interested in doing that?
All of those things. Really great question. I would say any project. I think particularly in the think tank land and in a lot of public procurement, the intellectual property and the capital of the researcher is primed over the actual outcome. So I think once a report gets written, that's like, oh, job done. And actually that's just getting started. And coming from a campaigns background, that's where I start to really get a hold of the potential for the research. And I think specifically in our relationship with Healthwatch Barnet, one of their chairs just happened to be at our launch event and was like, let's do something, let's really, change mental health services in Barnet. And they kind of needed, they had resources, but they kind of needed something to anchor themselves in. And I think we were a natural partner for them to go to their CCG and say, you know what, actually, You've just cut the funding of some providers for advice for carers who mainly look after with people with long-term conditions, but specifically mental health conditions. And we can actually prove that this is a problem, and it's a problem nationally. So it's kind of, I think there is potential, but what I'd love to see is people like you coming to people like me and then building these partnerships together, because I think there's a really natural fit.
Question is, are you open to a discussion about that? So maybe working again with a small grassroots sort of health organisation that's been working for a long time, but also I can cite one example of an organisation that demonstrates great data in terms of reducing the number of visits to primary care, and they had a university report commissioned to evidence their data, but it still wasn't admissible to some of the commissioners within a CCG. So, there's an issue there, and it seems to be one that's of interest to the health service as a whole. So I'd just be interested to explore it as my theory from someone who doesn't have massive expertise in this area. But
Yeah, well, as I was saying to John before, I intend to email you all and use this forum as a way to kind of extend this, because I don't want it to just end in a presentation.
Absolutely, thanks. So just before I hand over for another question, a quick mention that there will be documentation that gets circulated with information from all of the presentations and associated links and comments that can become a live document that we take forward and can serve as a place for convening some of these threads of narrative. Who else would like to address?
Hi, thanks, Tom. I'm going to try and make this question not too big.
Okay.
It might come across as a big one. But this afternoon and this evening, I'm sure, we're going to continue to see a combination of open data, linked data presented in a way with some stats that sometimes shock us, sometimes surprise us. I'm going to just say one word, which is accountability. Okay. We don't need this selling to us in the room. We get data, we get prevention, we get knowledge. How do we take this to make people accountable for what's happening? Is that a campaign issue? Is it a policy issue? Is it a QIP issue? How do we get this to become accountable for services that are delivering this type of impact stroke data?
That is the $1 million question, and specifically the £107 billion question, because that's how much the mental health or not dealing with mental health costs the UK economy. So I think you'd have to use a diversity of tactics, as people in the campaigns world would say. And I think there is space for local interventions to create real outcomes, and a lot of our work in other areas like the connected community work that we referred to before, our work in recovery services with substance misusers in West Kent does speak to the impact and power of really, really locally based solutions. And I think the issue of government funding particularly, or the parity of esteem between mental and physical health, is the hot potato. And I think a lot of, in every level of society, people are talking about it. And I think really what gives me optimism is for the future of healthcare to be devolved much more to much lower, so either to a community or a city-wide level. And I think there is potential with the RSA going into I can't remember who referred to it, but the City Growth Commission last year, we're doing a part 2. So there is a potential for health to be a really big part of that. So it's kind of not really an answer. But it's just really important to keep driving home.
Thank you very much. Another question? Perhaps one more question after this, and
It was me.
It was you.
Yep. Just checking. You aware of the work done on medically unexplained symptoms in Birmingham?
No.
Oh, okay. Because they did a project there that was very successful. It was one of the NHS Innovation Challenge winners a couple of years ago. And what they found was that there was a contingent of patients, a cohort that were being given a great number of physical health tests. They would come back again and again, and often the symptoms would be slightly different each time, so they'd be sent for different tests. And it became clear to clinicians in the city that actually the issues underlying were not physical, they were mental. So they developed a new pathway to treat such patients, and a training and education system for GPs and others to be aware of this pathway, so that people who showed signs of becoming these kinds of patients that were repeatedly admitted for tests where they couldn't find anything wrong with them, were given mental health rather than physical health treatment. And the estimate is that medically unexplained symptoms cost the NHS 3.1 billion every year. So it's a sizable problem nationwide. And I wonder if it might be skewing some of these statistics, because what we're seeing nationwide is that a lot of people who would be counted in your statistics as physically healthy are having a lot of extra tests. And they're not, so that statistic for the number of physically healthy people getting the physical health test is going up artificially. Really, they should be on the other side. They should be on the people with mental illness side. And so one of the statistics is too high and one is too low. Is that a factor that's been accounted for in your research?
No, it's not, because I think that wouldn't be a factor that would be accounted in the way the government collects the data. But I think we're more talking about a set of processes that are going wrong at primary care level in terms of tests. So really, there shouldn't be a distinction between mental and physical health patients, because they're all using the same services, and they should be producing equitable outcomes. So actually, I don't think there should be more testing of one or the other, and I don't think that would actually be significant amount of. I don't think it would be statistically significant enough to make that make our analysis not valid. And I think someone I can't remember who referred to, what does this mean? Why is this happening? I think a lot of the problems with when patients are presenting to clinicians and they're presenting with mental health diagnoses, a lot of the emphasis is on that mental health diagnoses and not on the physical symptoms. So I think there's an issue, there's a culture issue that we're identifying rather than just like an outlier, because I think it's systemic. So I think it won't just be about people that you referred to.
Thank you, Tom. I suppose what I'm raising is that there might be another endemic culture issue of people being treated the opposite way for physical symptoms rather than mental. But thank you for your answer.
Thank you very much. Would anyone like to raise a last question? Can I just, because this, it's great that everyone's in a space together today, but this conversation will continue over time, and having good video documentation will enable that.
Thank you. I was just, it goes a little bit back to what the gentleman down there said about accountability. And we already have these huge disparities in things that are quite obvious. I'm wondering, I'm concerned that as we see increasing privatization within public sector services, that and companies choosing to use data in specific ways and perhaps cherry picking the easy cases and avoiding the hard ones, and people not getting insurance and what have you, all of those issues. I'm wondering how, if we have so little accountability now, and that's already a $107 billion question, how we see that getting any better as it becomes more privatized in the future?
I think privatization is like almost, I think it's not as evident in the primary care sector as it is currently with NHS providers in hospitals, because the internal market there has been going along for quite a long time. So I think that there is an issue in terms of like a democratic deficit, in terms of the amount of public money that's going to subsidised shareholders, which are profiting out of our health. But I think, sorry, I just had a rant about privatisation. I think working with partners on the ground, and particularly CCGs, now that they're clinically led by GPs, is projects like this, if they're scaled, and actually I think we've only done a tenth of the job that we could, and with the money that we got, which was relatively little, which was £70,000 from the Cabinet Office, if we scaled that up, we could really galvanise accountability structures that I think would be quite formidable for people that are sitting on CCGs. And I think, if the role of Health Watch, for example, that's a statutory body that represents the consumer in the health system. If that was really utilised to the extent I think that it could be, you can start to deal with this accountability at local level rather than getting too wrapped up in the kind of macro problems of the health system.
Thank you.
Thank you very much.